Thank you.
So, yes, thank you very much. Teşekkür ederim. I hope everyone can hear me. Can you hear me?
Yes, yes.
Yes, you can hear me. Okay, so we can go on to the next slide. Yes, we are talking about anxiety disorders. One main anxiety disorder which is very frequent is specific phobia, as you can see on the left. But usually people with specific phobia don't go to a psychiatrist. Mostly patients that we see have panic disorder, and this is always together with agoraphobia. And then we have generalized anxiety disorder or social phobia. And separation anxiety disorder is a new anxiety disorder. It existed before, of course, but in the new DSM-5, it was included because it can now also be diagnosed in adults. So this is the only change in the DSM-5. Okay, we can go on to the next slide, please. I've developed a scale for panic disorder, the panic and agoraphobia scale. And as you can see here on this slide, it was also translated into Turkish, Panik ve Agoraphobie ölçeği. And this scale is also has been used by some Turkish scientists in the past in some clinical studies. So usually when we have many patients with panic disorder in our department, so this is the main disorder that we treat in our specialized unit for anxiety disorders, followed by social anxiety disorder and also generalized anxiety disorder. So we can go on to the next slide, please. In the last year, I have published 2 papers on the biological markers in anxiety disorders in search for the reasons why people have anxiety disorders. We have written 2 papers, and many famous anxiety researchers were included in these papers. So the first paper is on biological markers for anxiety disorders, OCD and PTSD, and part 1 was on neuroimaging and genetics, and the second part was on neurochemistry, neurophysiology, and neurocognition. So altogether, in these papers, we found, we can please push the button, the next slide, next. Yes, despite, no, go back, please. Yes, right, stop. Despite extensive research activities in neuroimaging, genetics, and neurochemistry, and neurophysiology and neurocognition, no specific markers for anxiety disorders have been found yet. With regard to treatment, improvement of serotonergic neurotransmission seems to have the best body of evidence. So although we have spent a lot of time with writing these papers, it was a little bit disappointing that we did not find any specific markers for anxiety disorders. But still, serotonin seems to be a very important neurotransmitter in anxiety disorders. So we can go on to the next slide, please. These are the drugs that are effective in anxiety disorders according to randomized controlled studies. We have first-line drugs, and these include the SSRIs. SSRI is selective serotonin reuptake inhibitor. And we have 6 drugs that are SSRIs, citalopram, escitalopram, fluvoxamine, fluoxetine, paroxetine, and sertraline. And all these drugs have been shown in many clinical studies that they are better than placebo in anxiety disorders like panic, GAD or social phobia. And also the SNRIs, duloxetine and venlafaxine, have been shown to be effective. And then there's a drug, pregabalin, which is a calcium channel modulator. It's also effective in GAD and social anxiety disorder. Other medications include the atypical antipsychotic quetiapine, but this is not licensed in any country in the world except Philippines and Venezuela. But there have been some studies showing that it works quite well in GAD. Then we have the tricyclic antidepressants, including clomipramine and imipramine. And we have the tricyclic anxiolytic opipramole, which is only licensed in some countries in Europe, like Germany and Austria. And we have the benzodiazepines, alprazolam, clonazepam, or lorazepam. There are many other benzodiazepines which are also effective in anxiety disorders. And a drug which is only used in the United States, like phenazine, it's not anymore in use in most European countries, but it's a very well-working drug for anxiety disorders. But it has some side effects. And then, I see a mistake here. We see azapirone, and it's not quetiapine. It should be buspirone. Buspirone is the azapirone, which is also effective in anxiety disorders. And then we have a reversible MAOA inhibitor, moclobemide. And according to new studies, lavender oil has been studied in Austria and other countries. It was also shown to be effective, and an antihistamine, hydroxyzine, is a very old drug. It's also been shown to be effective, and a melatonin agonist, agomelatine, was effective in some studies in anxiety disorders. So please move on to the next slide. So the drugs have advantages and disadvantages. So first-line drugs like SRIs and SNRIs, they cannot cause addiction and they are safe in overdose, but they have a latency of 2 to 6 weeks until the onset of efficacy. And in the first days, patients can suffer from jitteriness and nausea. And later on, like about when you have treated the patient for a couple of weeks, sexual dysfunctions may occur and other adverse events. Pregabalin has a very fast onset of action and is only licensed for generalized anxiety disorder, GAD. Somnolence, dizziness, and other adverse events can occur. And it has been reported that overdoses taken by patients with multi-substance abuse may be quite high. And second-line drugs, the tricyclic antidepressants do not cause addiction. They also have a latency of 2 to 6 weeks, but they have also anticholinergic or cardiac adverse events, weight gain, and they may be toxic when taken in overdose. The benzodiazepines have a fast onset of action. I mean, you take a benzodiazepine and immediately within minutes the anxiety is gone, but they can cause dependency and prolonged reaction time. Moclobemide is a drug that does not cause addiction. It also has a latency of 2 to 6 weeks, but a low effect size. That means the efficacy is not very strong. And it's only licensed for social anxiety disorder, and the studies were inconsistent, meaning that in some studies, the drug was not better than placebo. Buspirone does not cause addiction, also has the same problems, and also a very low effect size. That means the efficacy is not as good as the first-line drugs. Okay, then we can go over to the next slide, please. This is a slide showing what drugs patients receive all over the world. These are 155 million prescriptions all over the world. And you see the largest group are the benzodiazepines. 58% of all patients in the world get benzodiazepines for generalized anxiety disorder, and only 21%, which is only 1/5 of the patients, receive SSRIs and SNRIs. And then there are some other drugs like other antidepressants, 10%, anticonvulsants, 5%, and other drugs, 7%. That means that only 1 out of 5 patients receives a drug that is recommended by the guidelines, which are the SSRIs and SNRIs. This is a pity that in most countries, most general practitioners do not use the right drugs for the anxiety patients. Okay, next slide, please. And these are treatments for anxiety disorders according to the WFSBP guideline, which means World Federation of Societies for Biological Psychiatry. In the first line is the dark green line. These are the drugs that are recommended because they have sufficient evidence and a positive risk-benefit ratio. These include the SSRIs, SNRIs, and pregabalin. And with regard to psychotherapy, cognitive behavioral therapy has also sufficient evidence. And the next line, these drugs have a limited risk-benefit ratio. Quetiapine is not licensed for anxiety disorders in most countries. It has good efficacy, but you know that this drug is also used for schizophrenia, and it can cause the metabolic syndrome. That means people can have strong weight gain. And also the tricyclic antidepressants can cause weight gain and other serious adverse events. And the benzodiazepines can cause addiction. And the MAO inhibitor phenelzin may cause serotonin syndrome and hypertension and many other adverse events. Then there are some drugs that have positive but insufficient evidence. That means the clinical studies did not show superiority to placebo in every case. Buspirone, moclobemide, or pipramol, and hydroxyzine. And exercise is like if you run for 5 kilometers 3 times in a week, it may help in panic disorder. But the evidence is not as good as for the drugs. Then we move to the orange line, which is inconsistent evidence. That means for psychodynamic therapy, we have many studies showing that it does not work better than just a waiting list. It does not work better than a psychological placebo, and it's not as effective as cognitive behavioral therapy. And no evidence for herbal preparations. There's only one exception now, which is lavender oil. There have been some studies I will show you later. And autogenic training there's also no evidence. And there's negative evidence for beta blockers. Negative evidence means they have been studies in many clinical trials, but they did not work. And also for biofeedback, hypnosis, and EMDR, there is not enough evidence. It was all these 3 methods were shown to be not effective. Okay, please, the next slide. So I put together all the studies comparing antidepressants. We don't have to go through all these studies, but it showed that if you go down in the last lines, you can see there's no clear superiority of any drug. And the problem is that most studies were not powered for a non-inferiority comparison. That means if you compare like 2 times 100 people in one study, you cannot be sure that these drugs do not differ at all, because you need many more patients to show that one drug is better than the other. There have been some studies showing like clomipramine is better than imipramine, and imipramine was better than fluvoxamine, and citalopram was better than citalopram. But altogether, we would need many more studies to find out if which of these drugs are better. So we had this suspicion that because of the lack of power in all these studies, we have to find a new way how to find out which drugs are better than the others. So please move on to the next slide. So we did a meta-analysis. That was a pre-post meta-analysis. A pre-post meta-analysis means when you have a drug, and with the drug at baseline, you have maybe 24 points at baseline, and then with the drug after treatment, the Hamilton scale goes down to like 12 points. With the placebo, you start with maybe 25 points, and then it goes down to 16 points. So this difference between placebo and drug is called the treated versus control effect. It is a small effect because placebo is so effective. So the effect is measured is Cohen's d, and this is 0.5 in this case. But you can look at another effect, which is the pre-post effect, which is very simple. We just look at the drug and not at placebo, and the drug before and after has an effect of 1.8. So, but the pre-post effect size includes also the true effect, the placebo effect, spontaneous remission, and the tendency of regression to the mean. So, of course, we still need placebo studies, but when we look at the pre-post effect, we can see the amount of efficacy better, and it's also for the patient more informative to say, well, your effect size with the drug will be 1.8. He doesn't want to know if he is better than placebo. Now he wants to know, does my Hamilton scale go down from 25 to 12? This is the only interest of the patient. So please go on to the next slide. These are the results of our meta-analysis. So we put in this meta-analysis 234 studies with almost 40,000 patients. And we pooled all the effect sizes of all anxiety disorders. That means panic disorder, GAD, and social anxiety disorders. And we looked at medications. These are the orange dots. Then we have psychotherapies. These are the green dots, and control conditions, and also a combination of CBT and drug. And the findings were quite surprising. First, we found out if you go in the first line, you see that SNRIs have a high average effect size of 2.25. So as a group, the SNRIs were most effective, but of course there are other drugs like SSRIs, single drugs that had even higher effect size than the SNRIs as a group. Benzodiazepines were also quite effective, and the combination of CBT and drug was at the same size, 2.12, but you might wonder why a CBT and drug is not better than drug alone, but this may be due to the fact that there were only few studies, only 16 studies with this combination. The SSRIs, we have 62 studies, so we had an average effect size of 2.09, and the TCAs were a little bit less effective, but as you can see from the confidence intervals, there was no significant difference among the first 5 groups. But then the surprise, the psychotherapies were much less effective than the drugs. Relaxation was the best. It has a effect size of 1.36, and then followed by CBT. CBT included exposure therapy and individual therapy, not group therapy. It had an average effect size of 1.30, and this is based on 93 studies, so this is a very robust finding, and which was quite surprising for us that a pill placebo has the same effect size like cognitive behavioral therapy, 1.29. So there was no significant or no numerical difference. And this is also, pill placebo is also based on 111 studies. So it will be difficult to refute this hypothesis that CBT is not better than a pill placebo, which was quite surprising, and I know that some people do not like us for this result. And CBT group was a little bit less effective, and followed by psychodynamic therapy. So psychodynamic therapy was even less, markedly less effective than pill placebo, and also non-face-to-face therapies, which included internet therapies, were less effective. A psychological placebo is a control group. That means in the psychological placebo, there is a therapist talking to the patient, but the therapist doesn't have any idea about cognitive behavioral therapy. He is only a student, maybe without experience in psychotherapy. He's just talking in a friendly way to the patient. This is a control group which is often used in psychotherapy research. As you can see, CBT differs significantly from psychological placebo, but psychodynamic therapy, there's an overlap of the confidence intervals, does not differ. But unfortunately, mostly psychotherapy is compared to a waiting list, which has almost no effect, only 0.20. That means if you compare psychotherapy to a waiting list, you will always find a winner, but this doesn't show anything. So CBT and other psychotherapies should be compared to a placebo. Okay, we can go to the next slide. So we put all the drugs together from this meta-analysis, and the winner is quetiapine, which has a very high effect size of 3.39, followed by escitalopram, 2.67, and hydroxyzine, which is a drug, an antihistamine drug. And then there are some benzodiazepines like lorazepam and diazepam, and then paroxetine and venlafaxine. We don't have to go through all these drugs, but you can go down and find that buspirone is the one drug with the the smallest effect size. It's only 1.17, which is below placebo. And when you look at the yellow lines, this is a group comparison. The first yellow column is SNRIs. It has 2.25, and then benzodiazepines 2.14, and SSRIs 2.09, and the TCAs 1.84. So as you can see, as a group, the SNRIs are better than the other groups. But there are single drugs. If you go up again, escitalopram is an SSRI, which is much more effective than the SNRIs as a group. So with this meta-analysis, we can better choose the drug that is more effective for our patient. If you only look at comparison studies, you cannot tell the difference. But here it's very clear that drugs like escitalopram or paroxetine, venlafaxine are very good drugs. So please go to the next slide. Yes, agomelatine is also has 1.78. I put it in later. So altogether, the drugs that have been recommended by guidelines and show high effect sizes were escitalopram, paroxetine, the SNRI, venlafaxine, and pregabalin. So if you don't want to treat your patient with benzodiazepines because of substance abuse problems, so you should take for your patients these drugs which are very effective. Next, please. And also one funny experience that we made in our meta-analysis, that the placebo effect size grow over the years. In this slide, below you see that we looked at the years from 1980 to 2015. That means we looked at the placebo, only at the placebo groups. We had 109 trials for anxiety disorders which we could use for this analysis, and we put them into this analysis, and we found out that with the years the placebo effect was growing and growing, and it's funny, it almost doubled in the last 30 years. So next year, if you want to beat placebo, you have to be better than 2.0. And we have no good explanation for this, maybe because people believe more in placebos, because they believe more in drugs, because the drugs have become better. That's also true that drugs show higher effect size over the years. Okay, next slide, please. And then we put all the drugs in the psychotherapy arms together in the analysis, and we found that when the effect size of all medications were pooled, that means also the bad medication and the good medications were pooled and compared with psychotherapies, significantly higher effect size were found for medications. That is very important because usually in guidelines it says that drugs and CBT are the same. If you look at the British NICE guidelines, they say you should prefer psychotherapy before you take a drug. But that's not the right way, because for your patients you have better effect. That means for a patient, for example, that one patient who gets a drug has maybe 5 panic attacks per week, and people who are on psychotherapy have still 10 panic attacks per week, which makes quite a difference for the patients. Okay, next slide, please. Now I'm going to talk about new developments in the treatment of anxiety disorders. You have to stop me when I talk too long, because we started like 8:15, so I think I have half an hour. So I tell, if you want to stop me, just stop me if my time has passed. New developments. The next, push the button. Yes, pregabalin is a drug which is on the market since many years, and we have many positive studies. It's one of the drugs that has the most positive studies and no negative studies. So it is quite often used in Germany and the UK and other countries. I don't know how about Turkey, but it's also a very good drug. I use it very much, but there have been some concerns about overdoses taken by people who showed substance abuse. Next slide, please. Agomelatine is a drug that was also shown to be effective in 4 studies now. It was better than placebo, also better in a relapse prevention long-term study. And it was shown that it was agomelatine and escitalopram were both better than placebo in a comparison study. And another study showed that even the low dose of agomelatine, 10 milligram and 25 milligram, were better than placebo. So, but the drug is not licensed for anxiety disorders. What I've heard that the company does not want to get the license for anxiety disorders because they it will be a very complicated process to get the license in Europe. Next slide. Then there's a new drug developed by the company Lundbeck, vortioxetine. It has a complicated mechanism of action, and the data for GAD were somehow disappointing. There was only one study showing that it was effective. It was the study by Borwin et al. But in all the other 4 studies, it was not showing that vortioxetine works in GAD. It is a good drug for depression. I've used it quite often with good success, but not for GAD. So next slide, please. And there was a meta-analysis with 10 trials in patients who were depressed patients, and they took the patients who had anxiety symptoms. So it was shown that in depressed patients showing anxiety symptoms, the meta-analysis showed a significant difference from placebo. Next slide, please. Vilazodone is a very new drug. I've never tried it because it's not available in my country, but it's also a selective serotonin reuptake inhibitor and also a receptor partial agonist. It means it is somehow similar to buspirone, licensed in the US for MDD since 6 years now. And there have been many studies showing it works in social anxiety disorder, GAD, and also in GAD in 3 studies altogether. So this drug might be a new promise for generalized anxiety disorder. Next slide, please. And some studies, which all were published by Siegfried Kasper, showed that lavender oil extract, you know that lavender is a very good smelling drug, but the problem is that when you take this lavender drug, you have this very bad taste of lavender on your tongue, and many patients do not like it. And it was shown that it was better than placebo, and also it had the same efficacy as paroxetine and lorazepam. And in one study, paroxetine showed only a trend towards significance. And but still, we have to say that the database is not very good up until now, because like in the comparator drugs were used in a low dosage. Lorazepam was only used in 0.5 milligrams. This is not enough to treat anxiety, and also paroxetine was only 20 milligrams. There's no wonder that it did not show significant difference to placebo. So I'm a little bit skeptical about lavender oil. Next slide, please. And there are a number of options for treatment-resistant cases. We don't have to go through all this because of time. Mirtazapine, valproate, and inositol have been shown when every other combination has been tried. But what you can do, you can combine SSRIs and TCAs or olanzapine or pindolol or valproate. Okay, we can go to the next slide. So the switching studies are lacking. That means we do not have studies showing that one trial if one trial failed with one SSRI, is it worth to try another one? What I do all the time in my clinical practice, I switch from one class to the other or from one drug to the others, and usually after 2 or 3 drugs I have success. That means I tell the patient, sometimes we have to switch medication, but after 4 or 5 medications, you can be sure that we can treat your anxiety disorder. But there are not switching studies, only one switching study with pregabalin, which showed that it worked quite well if you switch to pregabalin. And next study, the next slide, please. So this is a case vignette. Mesut is a 20-year-old motorcycle mechanic. He suffers from sudden attacks with palpitations, chest pain, dyspnea, feelings of fainting, dizziness, fear of dying, paresthesias on the left side, fear of being seriously ill, and he fears and avoids situations like crowds, parties, public transport. And the fear is not that other people could criticize him, but he could get an attack, the anxiety that he could get a new attack again. Which diagnosis would you suggest and which treatment would you suggest? So, I think most people would say this is a case of panic disorder and agoraphobia. Please, the next slide. So, Mesut's diagnosis and treatment, the diagnosis would be panic disorder and agoraphobia, F40.01, and one treatment that would be effective would be a citalopram 10 milligram a day. You can also go up to 20 milligram, but not more than 20 milligram because of the QRS prolongation. And also cognitive behavioral therapy should work. Next slide, please. So these are my conclusions, and I come to the end of my presentation. There are no specific biomarkers for anxiety disorders, despite extensive research activity. First-line drugs for anxiety disorders are SSRIs and SNRIs, the antidepressants, better than benzodiazepines because they do not cause addiction. Medications are more effective than psychotherapies. And unfortunately, in the near future, no major breakthrough in the treatment of anxiety is to be expected. That means we do not have at the horizon many new drugs that could help our patients better. So I want, as a conclusion, I want to say teşekkür ederim. Thank you for your attention.